Good morning, everyone. Thanks for having me. I'm Christopher Bailey from Hopkins, and I'm going to be discussing some fun biliary cases, and hopefully we can pull some learning concepts through each of these cases. So kicking into it, we've got a 51-year-old female, end-stage liver disease due to ETOH use, status post-orthotopic liver transplant in November of 21. Unfortunately, her transplant was complicated by hepatic artery thrombosis, so we're in the realm of biliary ischemia, biliary stricture formation. She subsequently developed liver abscesses that coalesced into a large liver abscess that was drained and eventually converted to an internal-external biliary drain after her ERCP stent drainage did not provide adequate biliary decompression. So axial CT images of this coalesced multifocal abscess biloma formation. So we started off this case by first decompressing the system, placing an initial 10 French APD all-purpose drainage catheter into the biloma, which drained purulent bile. We gave her a couple of weeks to decompress, defervesce, and her bile turned clear, but she clearly had a connection to the biliary system as we postulated, given the biliary ischemia. So we brought her back, performed cholangiogram, and decided to convert this initial percutaneous biliary or this initial abscess drain into a percutaneous internal external drainage catheter. So converted our APD into 8 French sheath, used a 15 millimeter Amplatz gooseneck snare to snare out the ERC place plastic stent to give us some running room to get through, used an 035 system of catheters and wires to get down, and eventually placed a traditional internal external biliary drain through that initial biloma into the biliary system to give some biliary decompression. At Hopkins, our surgeons, both on the HPB side and the transplant side, love us to put these patients on the upsize train and get them to 16, 18 French, higher Schulte, silastic biliary tubes, which is what we did for this patient. But what I want you to note is here on this final cholangiogram, once we hit goal, she has multifocal filling defects, which are representing biliary sloughing, debris, stone formation in the setting of this hepatic artery thrombosis. Unfortunately, this patient had recurrent bouts of cholangitis with increasing pruritus that led her back to drinking, which seemed to be the only thing that would help her pruritus. So kind of a double hit from, the psychiatric perspective and also from the management of her failing OLT. So we decided to offer cholangioscopy to help clear this debris and assist with the biliary drainage. So using a spyglass system, this is what we saw as we entered this track. So we put down a 16 French peel-away sheath through that biliary drain, and you can see this thick, epithelial inflammation, debris, and stone formation. So we decided to do laser lithotripsy with basket removal over several sessions to clear this system. This stone that she had from biliary sloughing was very resistant to low wattage laser lithotripsy. So we actually ended up using what is a modified holmium or a modulated holmium laser at 120 watts using a dusting protocol of lithotripsy, which is low energy, higher frequency, using this fiber tip and a stone retrieval basket to basically break up the stones through several sessions and do basket retrieval. And fortunately, we were very successful. So this is November of 23. You can see this patient had been dealing with this for about 4 years. Due to the recidivism, she was not a transplant candidate, or retransplant candidate, I should say. And back in November of 23, you can see multifocal filling defects. The cholangiogram's not very clean, but you can see we actually cleaned it up quite a bit, given that we're fighting biliary sloughing that's ongoing. And that was also reflected in the lab values. You could see that her alk phos and her T-bili remained quite low during our sessions of scope. So currently she's doing well, resolution of the pruritus, improvement in her labs and the cholangiogram. Will she recur? Almost certainly. She's going to have to come back for other sessions of biliary scope and lithotripsy over time as the underlying insult of that hepatic artery thrombosis isn't resolved. But hopefully we can, recidivism will get better and she can perhaps progress to retransplantation. Case 2. This is a 21-year-old female with liver failure after taking Levaquin, really unfortunate complication, super rare. Subsequently developed cirrhosis with portal hypertension, underwent OLT in October of 2021. She had side-to-side cavocaveostomy, end-to-end portal vein anastomosis, end-to-end arterial reconstruction, and end-to-end biliary reconstruction. Unfortunately, like our last patient, she experienced arterial thrombosis that we were unable to salvage through thrombectomy, stenting, and the like, and now she's presenting with biliary ischemia as well. In this case, which is a good corollary case, our GI colleagues, of course, tried first. They were able to cannulate the biliary anastomosis, but they couldn't get through the central obstruction, unfortunately. So we proceeded with traditional percutaneous biliary drain placement, two-stick technique, 22 gauge to opacify, 21 gauge diamond tip to access a peripheral duct, nitrix wire, AccuStick set, convert to an 035 system, and placed a 10 French biliary drain through and through. We put her on the Hopkins upsize train and got her to an 18 French Cook biliary tube, but you can see over-the-wire cholangiograms persistently demonstrated this high-grade obstruction at this biliary anastomosis that was resistant to cholangioplasty and balloon sweep. So again, we tried some cholangioscopy to see what was going on there. So over-the-wire cholangiogram demonstrating this multifocal filling defect centrally. And when we get in there, very similar to our first patient, debris, biliary sloughing, we did laser lithotripsy and basket retrieval again. Then followed by cholangioplasty to actually open up that area of stricturing where those stones were actually getting stuck. And I want to show you our setup for one of these sessions. Academic institution, we went extreme on this, but this is myself and one of my partners, actually, Dr. Nima Najad, working through this case. We have our cholangioscopy set up in the corner. We brought IVUS into the case because we just wanted to prove that this stricture was truly a stricture, because there was almost no wasting every time we did cholangioplasty. And then one of my partners, Dr. Harjeet Singh, has a optical coherence tomography project. So we put that probe down during this session to characterize malignant versus benign biliary stricture. Topic for another day, but you can see we went the distance with this case. And subsequently, she ended up passing clinical trial. She remains decannulated right now. Her symptoms have been well controlled for the last few months. Again, like our other patients, she's almost certainly going to require biliary reintubation and some additional stone extraction as time goes on until we get her to transplant. Our surgeons are hoping to delay her to transplant as long as possible since she's so young and the graft is functioning okay right now. But again, cholangioscopy, another tool you can pull out of your armamentarium. Case number 3, we have a 54-year-old male, history of primary sclerosing cholangitis, status post-deceased donor liver transplant in 2008. He had recurrent cholangitis many years later, and the surgeons actually converted his anastomosis to a Roux-en-Y hookup. He then subsequently developed HJ stenosis, causing cholangitis. Couldn't get the HJ cannulated by ERCP, so he underwent PTC PBD with us in June of 22. Again, two-stick, placed a 10 French biliary tube through and through. 2 months later, patient presents with feeling ill, noted fever, small volume of blood draining from the tube. Obvious indication, we're thinking cholangitis, so we put him on the upsize train and eventually got him upsized to 18 French Cook biliary drainage catheter, internal, external. But then developed an episode of hemophilia and then recurrent hemophilia 2 days later. Took him obviously for cholangiogram, did digital subtraction cholangiogram to see if we could light up a portal vein source, couldn't see anything, but he had significant clot that you could see on the cholangiogram in his HJ lumen, so we proceeded to angiogram at that point. So we first did we got right groin access, went up with the 5 French, Simmons 1, performed an angio and multiple obliquities with the tube in, and then the critical portion here is you got to take the tube out because the tube in and of itself will be tamponading whatever bleed is coming through the arterial system. And we noted by that blue arrow that's actually not lined up very well that there's this little outpouching there. Thinking pseudoaneurysm, multiple obliquities didn't really prove that for us, and we never had any kind of bleeding. So my partner had done this initial angio, said, you know what, let's watch the patient, let it be. So we had a little bit of a multidisciplinary discussion the next day in morning conference and said, you know what, we think that's a pseudo-A. The guy's been having recurrent hemophilia. Let's just bring him back. So I hope this video plays. So we wired the tube, put in a 16 French POA, and did some cholangioscopy and actually some IVUS. And you can see there's this red biliary epithelium, and you can actually see some pulsatility there, which was surprising. So we got our IVUS out. We could find that vessel that was sweeping over the biliary system, And we saw this little outpouching there that, for all intensive purposes looked like a pseudoaneurysm to us. And on that initial cholangiogram, when we put the scope down, you can see he's got clot again in that HJ. So we proceeded to angiogram once again, groin axis, 5 French Simmons 1, and this time we went out and we selected multiple branches until eventually we blew out a branch there and proved, as you can see with the arterial extravasation down the track of the biliary tube, that in fact was a pseudoaneurysm. Unfortunately, that positioning required us to really coil off quite a bit of his hepatic arterial system to get control. But we got control there, and he collateralized from his inferior phrenics and did quite well in the long run. But we thought, hey, this is a this is a case that we've never really seen the pseudoaneurysm formation. It's usually we get portal vein fistula, you get just arterial blowout, but it's actually a very well described entity, in the realm of percutaneous biliary tube management, formation of pseudoaneurysm. But cool corollary case that we were able to show it on IVUS and also with cholangioscopy as well. Companion case, but this is a companion case based on diagnosis. This is a quick one. So this is a 25-year-old male with a history of primary sclerosing cholangitis who was lost to follow-up for 13 years and then presented to us with cholangitis and hyperbilirubinemia up in the 30s. He underwent ERCP with plastic stent placement. Unfortunately, that didn't do much. What I'm highlighting with this case is just it was the most glaring example of PSC that I'd seen just as a patient who had been out in the world untreated for many, many years. You can see the key features, cholangiographic features of PSC, multifocal stricturing, beading, pruning of the distal branches, irregular walls, and dominant strictures. Bilaterally, actually. So he was just a glaring example of what PSC looks like when it remains untreated for years and years. As such, we got perc access, got down percutaneous biliary tube placement. We were able to actually bridge this gentleman successfully to transplant, which was great. This is an oddball case. So 57-year-old male, history of Crohn's, UC, ETOH cirrhosis, recurrent HCC, had a recent right hepatectomy for that. Remote history of motor vehicle accident that resulted in excision of an extrahepatic bile duct with Roux-en-Y reconstruction. So the take home of what I'm trying to build here is inflammatory bowel disease, cirrhosis, and a surgical abdomen, essentially. An abdomen that's an adhesion, fistulization disaster. Unfortunately, the most recent right hepatectomy was complicated by hepatic abscess biloma formation along the resection margin. And outside hospital had placed a drain and eventually had converted those drains into internal-external biliary tubes. He presented to our ED with a feeling of tasting bitter, like a bitter taste in his mouth every time he flushed his superior biliary drain. So we started with tube cholangiogram, didn't really show much, so we did our over the wire, and lo and behold, he had developed a biliary bronchial fistula. As you may recall, his history includes inflammatory bowel disease, multiple surgeries, so he's a setup for fistulization. We had gone through many derivations of how we would actually manage this, covered stenting, coiling it off, things of the nature. And then we had come to the conclusion, you know what, why don't we just get some glue into it? So we rewired his superior biliary drain, placed a sheath, used a Compi high-flow Renegade microcatheter, and were able to delineate a small fistulous connection between a tertiary biliary duct and the bronchus. And we actually glued back with 1 to 2 Lipiodol, glutathione, Trufil, and BCA, and actually got a great result. And then what we left in place was a traditional internal-external PBD, upsized to 14 French, a all-purpose drainage catheter within the tract that we eventually backed out over time as we allowed it to heal. And the fistula remains resolved. Unfortunately, he's still cannulated from a percutaneous biliary tube perspective just because of stricturing and multifocal disease process within his biliary system, but the fistula has shut down for now. So rare complication of inflammatory bowel disease / surgery / all of the like at once. Quick case here, post-op day 3, orthotopic liver transplant, high biliary output from surgical drain, CT obtained. got an axial CT here. You got a central collection, air in the bile ducts, surgeons and everybody thinking, this is an HJ leak. And this just was a spectacular HJ leak in terms of size. So got 22 gauge Chiba access. You can see very thready, decompressed bile ducts, undilated system, secondary access with a diamond tip 21 gauge. And you can see just through the needle, you have a huge HJ leak with contrast extravasation all throughout the, porta hepatis central region. So we placed a 10 French biliary tube. We were fortunately able to get back into the bowel, but that patient had to go to the OR. We've tried with these huge biliary leaks upsizing 20, 24 French, but when you get to this size, these leaks are just not going to shut down, and you're just going to have such high biliary output. And whenever I see something like this, we always send that fluid for amylase as well, because where there's an HJ leak, there's probably a PANC leak there, and that has to get controlled. Couple more cases before I run out of time. This is another oddball of a case. 75-year-old female with a history of remote RP sarcoma resection not performed at our institution, cecal volvulus, perforation, complex resection, including the gallbladder, which is important for this case, and ileostomy creation, presents to us with a large biliary leak evident through her JP drain. So we were consulted for biliary tube placement for diversion, but everybody's unclear what injury occurred here. So percutaneous access once again, and you can see that there's contrast filling of the gallbladder fossa, and that's actually where the JP drain was coiled. The actual surgery, as I mentioned, was not performed by us, so we were very unclear what was resected in the past versus currently. So we did our usual practice of upsizing, getting across that leak and placing an 18 French Cook for biliary diversion. Often that will work, but in this case, she had 4 weeks later, continued leakage on over-the-wire cholangiogram and tube cholangiogram from that cystic duct remnant. So similar to our bronchial case, we decided to glue it. So exchanged out our system for a sheath, used a 7 French and 5 French MPA Cumpy combination with a high-flow Renegade microcatheter, glued back in the cystic duct, and then coil embolized with a couple embolds, 3 millimeter coils. And we actually had a durable response. So all the contrast filling is from the actual case, but her biliary tube output did cease, and she was able to lose that JP drain without any recurrence of filling in the gallbladder fossa. So good outcome from that perspective, and again, another use of glue and coils in an unusual place to control biliary mischief. I think I'll make this my last case. This is a 61-year-old female with a history of gallbladder CA, biliary obstruction, status post metal stent placement. It was a viabil by GI 6 months prior, now presenting with cholangitis. She had failed GI cannulation from below, and what they had noted on their scope was obstructing tissue. So she had recurrent tumor basically growing within this covered stent, unfortunately. So we placed an anchor drain in the acute setting on the right side because her biliary ducts were so dilated, and we basically had to bail her out from biliary sepsis initially. But once she had defervesced, we brought her back for crossing. So initially, this anchor drain helped us get through that acute period, but it wasn't providing meaningful biliary decompression. We really needed to get through and through and get side holes across this multifocal obstruction of her biliary tree. So we actually started with left-sided access because it was just an easy ultrasound stick, stuck it with a 21 gauge diamond tip, got our Nitrex AccuStick in, but we just couldn't get through all this soft tissue. And it was clearly evident when we were trying to cannulate with our 035 system, we were banging up against, some hard recurrent tumor. So we concurrently then wired our anchor drain. We had gotten kind of halfway down the stent with our sheath system, and actually RF wired through this stent, which worked, and was able to get a wire through there, an 035 system, and then did cholangioplasty to basically break open the interstices. And working together basically through multiple sessions, we were able to find a channel through this and actually obtain enough of a channel that we could also swing down from the left, allowing us for access bilaterally and placement of 2 10 French biliary drains, which we were able to eventually upsize to 14. We weren't able to go much bigger on the right due to the interstices. The most we could ever really squeeze through there is a 16 because the stent will only stretch so much. But again, using some multiple tactics to cross through an occluded biliary stent placed by our GI colleagues, something where we can really provide a service for the patient that they don't have much option otherwise. And I think I'll conclude there. Thank you everybody for your time, and I hope you found the cases interesting.